Hey, Astro All Things Dentistry, the place where we're passionate about sharing those unwritten hints and tips of dentistry. Today is an amazing day. We're going to finish the case on the miracle tooth, and that's what the oral surgeon, also known as Quiet Guy, the nickname that my third son gave him. He gives everyone nicknames. So what happened was about 6 months ago, Quiet Guy took tooth number 38 and transplanted into tooth number 37 spot. This is a first for me, first for him. And I was taking a look just before he had read this, and this is, literally 20 years ago, this article. It's very funny, actually. Autogenous tooth transplantation, alternative to dental implant placement. Likely not. But anyways, go ahead. It's for entertainment if you want. But if you're going to do this, it tells you kind of how to do it. And the success rate actually shows from 95 to 98% success rate. So it actually works, but I think everything, the Swiss cheese model, everything has to line up properly. So let's go ahead and take a look at this. So this is really, this picture here is actually right post-operative. And what he'd done is he extracted the 7, you'll see why in a second, and he took like a 014 nickel titanium wire and bonded it. So if this is the original situation here, the third molars were getting extracted anyways, all of them, if I recall. And he was sitting there in his office thinking like, why don't we take this 3.8 and put it in a 3.7 position, because this is non-restorable. So unfortunately, I wasn't able to get any video coverage. Perioperative, so during the operation, the tooth is now extracted, 3.7, and then this is placed in the socket. He placed it in there, but it seemed to fit, and you actually probably would never even know this was an 8 in the spot of a 7. So that was, like I said, 6 months ago. This is now post-operative radiograph taken with the 014 nickel titanium wire, and the tooth is in place, and that's it. A bit of post-operative footage here. We can kind of do like a TikTok dance back and forth with the patient here, but essentially what we're seeing here is it looks, so he reduced the occlusion, so it's in occlusion, or it's out of occlusion, reduced it. I sutured up the socket, just nice and light. And there's a bunch of, according to this article, there's a bunch of different ways you can do this in terms of stabilizing the tooth. You can use sutures to stabilize it. You can use nickel titanium wire, whatever you want, just some stability. So roughly 2 to 3 weeks later, we did an initial pulpectomy, and we placed calcium hydroxide. So what happened was we placed calcium hydroxide, and then during the procedure, so I don't have the pulpectomy here, I have the completion of the case. During the pulpectomy, what happened was I couldn't get patency on any of the canals on the mesial. So there's 3 canals in this tooth, and I was like, well, I don't know what's going on here, because my file was doing like a U shape in the mesial canals. It was almost like it was just a horseshoe. So we took calcium hydroxide. This is calcium hydroxide. This is Fuji triage. Actually, it's because we're going to keep it in the tooth for longer than a couple weeks. And so we took a cone beam to see. I wanted to figure out the anatomy of the mesial and distal roots. So let's speed along here, and we're just doing some measurements. And we're just going to circle around the tooth. And one of the most important pictures that I can give you is this one right here. So this is the mesial root. This is Fuji triage. This is the lingual portion of the mandible. This is the buccal. You can kind of see where the concavity with the mylohyoid may origin or insert. And this is kind of where the buccal shelf will start. So if this is the mesial root of that third molar, if this is lingual, so this is our mesial-lingual canal, and it connects with, and there's a mesial distal or a mesial buccal, and they join. And you can see they kind of exit mesiolingually here. Just kind of, if we go back to another, they exit here mesiolingually. Now I still could not, even after today, I could not get patency, but I'm not too concerned because we were getting some osseous healing. So let's take a look at our radiographs. This is post-operative. I let the cat out of the bag. Sorry. So this is right after we placed calcium hydroxide about, I don't know, let's say 4 months ago. And I wasn't happy with getting complete cleaning of this mesial root, and I wanted to figure out what was going on. So we took the cone beam after this. Now this is approximately 6 months later. That's today. So you can see we're getting some healing. We've got a nice PDL. It's not ankylosed. I mean, there's probably a may become ankylosed or resorbed or whatnot over time, but right now he's got a tooth. rather than as compared to what he had before, which would have been nothing. So you can see our Fuji triage. We have at least, the literature supports roughly a 4 millimeter thickness of any type of, not any, but a restorative material. And then we have still the 4 millimeters thickness. So we got minimal leakage. There's always going to be some sort of leakage, but it was minimal with that triage, and it lasts a lot longer than CAVIT. And then we still have our dentogenic material, our calcium hydroxide in the canals. So we're happy with the outcome here. And the patient, the tissue looks great. The patient is healing well, and he's asymptomatic. So we're like, okay, well, let's finish the case. So let's see here if we keep going here. So this is the case right before we did the root canal. So approximately about 6 months ago. So I'm sorry, I'm skipping back. So you can see we've got some great healing. This is about a month. This is about 2 weeks after the procedure had happened. You can see we're getting healing of the socket. Our gingiva looks great, and we don't have our access hole. So patient's happy and we're good. So fast forward to today, where we've completed the pulpectomy earlier, and we've got some great healing. Got some healing. The patient's asymptomatic. So what we're going to do is we're going to finish this root canal today. So I'm going to pop into this Fuji triage. You can see it's a great material. I mean, this has been in there for 4 months, and it's not even worn away. So I find this stuff really hard to cut through with a round burr. So what I do is I took this, whatever I could find. It was actually a transmetal burr, which is great if you're cutting through metal like gold, not so much amalgams, but especially gold crowns, and you don't want to chatter. This is a great burr because it's just designed, the way the flutes are and the fissures are designed to cut through metal, and it just makes this like butter. So here we are. We've removed our provisional restorative material, and you can see, let me bring that down. Here's our mesial canals. So this is our mesial buccal, and this is our mesial lingual, and this is our distal, and it's fairly ovoid. So this is our calcium hydroxide. So what we're going to do is we're going to do a combination of lots of irrigation and some mechanical with Wave 1 Gold Large. I don't get paid by Wave 1. I don't get paid by Dentsply, but that's a product I've been using for a long time now, and I love it. So what I'm doing here, there's lots of different ways to remove calcium hydroxide. I just take full strength hypo and just rinse the heck out of it. Today what we're going to try to do, so one of the reasons why we did place calcium hydroxide in here, other than that's what's recommended, so what you're seeing here is we're going to rinse. I'm going to take my sonic activation. We're going to try to get rid of as much of that calcium hydroxide as possible. But really the idea of placing calcium hydroxide in this case was not so much to two-step it, but in my mind, remember the cone beam is going to come up in a picture here in a second, is to remove that material where it's all the vital tissue where these two canals join. So I'm going to take this right down, and we're going to clean out. My goal for today is to remove as much of that calcium hydroxide, but also what we're trying to do is I'm trying to clean all this out. So calcium hydroxide is beautiful because it's antibacterial, but it also dissolves vital tissue. So my concern was there's going to be vital tissue sitting here if we didn't place calcium hydroxide, and it may decrease the outcome of our root canal. So what I wanted to do was, knowing that this was a horseshoe, and knowing that when I took my 10 file in my pulpectomy stage, the file, it kind of went down to length and then curled back up, and then I pull it out and look like a horseshoe. So that was the two reasons why we placed calcium hydroxide in this case. Apart from just that article saying you should do this, why are you doing that? And for me, that was one of the reasons here. So I'm taking my Wave 1 Gold. You can see we're trying to mechanically remove any of that calcium hydroxide. You see that bend on that file? If you don't bend your files to try to get them into these orifices, and you're struggling trying to get your files into the orifices, give it a bend. You may need to bend it quite a bit. I bend it quite a bit there, and it just slides right in like that. Just watch this. Like that. And it's just so much easier. So if you're using heat-treated files, start bending them to get them into the canals. It makes your life so much easier and faster, because we've got straight line access into these canals. Arguably with heat treated you don't need it, but just in this case we did it. Actually, we started this case with one of our younger dentists. That's what happened. So we're going to irrigate, 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 irrigate. Constant, tons of irrigation, and you can see all the debris, whether it's dentin, calcium hydroxide that's coming out of there. You can see a lot more debris. So we're going to make sure that we irrigate and we activate this. I'll be using an activator, an endoactivator sonic. I still need to try an Eddy by VDW, and I'm also going to be doing old school manual dynamic activation. So one of the things that was really important right there that I wanted to show you was, if you see right now, we know that these two canals join, right? Watch, usually when we aspirate our irrigant, so I'm going to use my irrigation syringe. You can watch the needle, the syringe kind of come back up. So I'm actually removing, I'm using it like a vacuum, suction out of the mesiobuccal canal. But nothing comes out of the mesiolingual. So sometimes what happens is that makes you, that's a great indication that it's like not always do these things play by the rules that you think they're playing. So what does that tell me? It's like, oh, well, I know that they join, so I got to clean that out even more to make sure that all that debris is out of there. That's the beauty of having a cone beam. So that's the one thing I wanted to take away from that. Also, we do this sometimes when you do that aspirate your irrigant thing, you can fool yourself in thinking like if they both drain, which you'll see at the end they do drain. If you don't have a cone beam, you can fool yourself into thinking that they join at the apex, whereas they may just have an isthmus. So you can see that distal canal is fairly wide buccolingually, so we're going to make sure we irrigate and clean that out well. So using my apex locator, I tried to get that file out of there, doing lots of little bends, and I just couldn't do it. When I placed that file to length, it just came to one green bar. And if you see one of the videos I posted a while ago from Dr. Domenico Riccucci, he talks about going to the one green bar on the apex locator. Happy with the results, so we're going to go to the green bar, not get patency, and we're going to irrigate the heck out of this thing. So again, what I'm trying to do in that mesial root is remove all of this material here. Is patency critical? I don't know. Put your comments below. What do you think? So what I'm going to do here is, you saw me activate with the activator. Now I'm going to go old school with this manual dynamic activation. Just any way I can just irrigate all this little area out, try to bounce all that stuff out of there. I actually took that 40 file, I bent almost a 90-degree little bend at the apical third, try to scrape anything out of there. I don't know if I left it in here. It was kind of boring. So we're going to do this, and you'll actually see, now we're starting to get some movement of the irrigant. You'll see in the mesiolingual canal. See it's starting to move now? Boom, boom, boom. You can see it pumping up and down. So now I'm starting to feel better that, yes, we're getting all that material cleaned out, all the debris. Got to be careful when you're doing this manual dynamic activation, because you're putting a wedge in a wedge. So the one wedge is your cone, and the other wedge is your canal. And there's always a small possibility of extruding some sodium hypochlorite into the apical tissue, so you gotta be very careful. I wasn't too concerned in this case because I didn't have patency. It might be patency, but just keep that in mind. I have done it in clear teeth, and it actually works to clear out that apical portion. So after manual dynamic activation of all the canals, you can see now we're irrigating more. So I'm using full strength sodium hypochlorite. I'm just irrigating like crazy. I'm going to do another rinse with 17% EDTA and then finish with my my sodium hypochlorite. But today is really about getting rid of that calcium hydroxide, getting a little more machining with the large wave one gold. It's a 4505, but then just irrigate the heck out of that. So more activation. It's really funny, when I started this root canal, the surgeon came in the room, and he was talking, and I was fiddling around with my iPhone adapter, and he walked out. Just before he walked out, he said, "Wow, it's the miracle tooth," and I just couldn't stop thinking about the miracle tooth. So that's where that term came from, if I haven't mentioned that. So we're going to use some activation. If you are new to my channel, go ahead and like or subscribe. I'm aiming for 100,000 subscribers, so if you subscribe, that help me on my way. It's just kind of a goal I've had for the last year or two. So I can't believe we're already at almost 92,000. So thank you so much for those who support me. I love what I do. Passionate about sharing these crazy hints and tips about endo. All right, so let's keep going here because this is a little bit boring. So just activating. And one of the things that I find interesting is just all the, see how it's, see if I can get it, it's translucent. So see how the irrigant is very see if I can get it. See how it's translucent? So once I start irrigating, it just clears out all that material. So I'm hoping that, and that's really what it is, I'm trying to get all of that junk out of the canals to make sure we get a great outcome, because that's what we're looking for. So we'll speed along here. Stick around for the end because you'll see what we're going to do for restorative. You might actually giggle if you've seen this before. Okay, so what we're going to do here is I'm just checking. Oh, it's like a smiley face. I should screen capture that. So there's a smiley face, and then what we're going to do is we're going to aspirate my irrigant so it does come down and out of the mesial buccal. So now we've got a little more, I feel a little bit better because now, boom, now I've cleaned out a little more. I'll never know of that area between the mesial buccal and mesial lingual. So let's keep on trucking here. All right, so what we're going to do now is we're just going to take some paper points. We're going to dry. What I do is I'll place a whole bunch of paper points, place some air. So I really overdid it with the paper points because I know that there's again that little area between the two canals. I want to make sure it's completely dry. Sodium hypochlorite. So I'm going to place my paper points in. I'm going to blow air on it, and then what it does is it wicks. The idea is to wick some of the moisture of the sodium hypochlorite up through the paper point as the air blows over. Now, does that happen? I have no idea. So I'm just checking to make sure my paper points are dry or wet, moist, by placing them on the tooth. I don't have patency, so I'm not going to be using it to check my working length. We're just placing it down to make sure we can get that dry. So I did trough briefly before. This is little remnants of calcium hydroxide just on the pulpal floor. I'm not too concerned about those. And they're actually little parts that really dried out. A little bit of calcium hydroxide just in the isthmus there. I'm not too concerned about that. I did trough that before looking for a middle mesial, but there was none, if you were wondering. So we dried it out. I'm going to keep drying like crazy, make sure it's super dry. All right, so here I'm trying to work on my, because this is the first time I've used this iPhone thing. So what happens is it autofocuses. So I'm trying to get my best here. So we're up a thing of power. So this is our mesiolingual canal. This is our mesial buccal. There's our distal. You can see it's wide. So I'm using a single cone technique. I was thinking about doing a thermoplastic backfill. This here is actually, if you've been looking at this, a bit of triage. So we're going to flick that out of there before we put our final restoration. So what we're going to do is we're going to take, and now it comes out of focus. I'm not really impressed. So look at this. I'm like, oh, I can get a great shot of the sealer coming up, and it's out of focus. That was choked. Anyways, I'll touch the screen, and there we go. Now it goes into focus. So we're going to place our sealer, and then I'm just going to take my cones, and we're going to place them down to length. I'm going to pump a few times, and then in the distal, because it's wide buccal lingually, I'm going to place 3 cones, just to wedge them in there. Pretty straightforward. I'm going to weasel another one in there. Boom. So we've got 5 little rubber carrots in our tooth. And then what we're going to do is take a radiograph. So what I do is I'll take the radiograph with the patient laying down. I don't even really keep the rubber dam on. And this is one of our straight on. Well, it's kind of a shift shot, so I'm happy with the length. You can see we're within 1 millimeter of the radiographic apex, which would be kind of here, I'm assuming, and same on the distal. So I'm really happy with that outcome, and we've got a fill here. Remember, it's wide, so we're trying to, and this is even more of a shift. So you can see I'm thinking that this is that area between the two canals that I've filled with sealer, and also we've got a nice wide obturation with the in the distal. So I'm also looking at the PDL. I'm happy with that. The PDL space. Let's look on this other one. So I'm happy with this PDL. It's a little bit wider here, but I'm happy here. So let's go ahead and we're going to sear those cones off. Here's a tip. If you have a hard time with searing cones, which most of us do, what I do is I'll sear them off kind of right at the occlusal surface, the caval surface margin. I think that's what it's called. I can't remember. It's been a long time. So I'll sear it off here, and then I was going to be like, oh, I'm going to create a nice video for people to watch me do this nice and daintily, but I actually make a mess out of it. So don't do what I have to do here. And it's out of focus, so I'm going to fast forward. I wasn't very happy. So what I'll do is I'm going to, yeah, you see I was in focus and I'm out. But the one key thing is I have the plugger, or the heat carrier, curved. I bent it at the bottom, at the apical third. You see how it just comes in nicely? I'm going to go right towards tooth structure. Sear it, pull out. This, up, and it didn't come out. And it should have, but it didn't. And then I just make a mess out of everything. So I'm actually going to fast forward through this. It's kind of messy. We'll get to the end here, so we're going to clean it up. We're going to do a little bit of compaction. There we go. All right, so here we are now. Placed our gutta percha, and you've got a nice wide fill there. And now what we're going to do is we're going to get an amalgam restoration core placing here. Now I know what's going to happen in the comments, and I was thinking about that as I was placing this. I'm going to refer this back for a zirconia crown for one of our other dentists. So I'm sure I love placing amalgam. I've been placing it for 20 years. And it's quick, it's easy. I'm just flicking off some of that triage. I'm going to flick that out of there and get that out of there. But I'm sure that most of you that are watching this are placing composite restorations, which arguably probably would be faster and more biomimetic. But you know, I mean, I'm gonna go to the grave with amalgam. Anyways, so I placed my amalgam. I'm gonna finish. You know, I'm not making it look nice. We're just kind of cleaning it up, getting out the fissures. There, it's burnished, and we're good to go. Off comes the rubber dam. So what is the outcome at the end of the day? Well, here's our straight-on periapical radiograph. So we have, again, I'm really happy with the fill, and I'm happy with the PDL. It's not ankylosed, but gosh, who knows if it's going to happen. I forgot to mention we actually had some osseous breakdown initially from, I can't remember if it was here or here. Oh, that's what happened after a week after I pulled out a little spicule of bone. So we were a little concerned with the osseous crust breakdown. But here, it looks like it's starting to come back, and we're really happy with that. And then this is a shift shot, so a distal shift. So same side lingual, opposite side buccal. So distal shift, so the x-rays come, the radiograph beam is coming from here. So same side lingual, distal shift. So this will be our lingual canal, and this will be our buccal canal. Same side lingual, so this is our distal lingual, and this is our distal buccal. And you can see we've got a nice fill here, filled with sealer. And that's it. So hopefully that, and we're going to follow up in another year, and or another 6 months. So it'll be a year since placement, but hopefully you enjoyed it and can take a few things away from it. Here's another, this is another treatment that we've got in the books. I'll just show you right now that I just need to edit the video. So we've got a retreatment. We had a large removal, or large resorption of the apical portion, and then we've finished it with a large amalgam and our obturation here. So anyways, look for that, and we'll talk to you soon.